All right, so let's wait for a few people to come on and we will bring on Dr. Nejad and get this going. So thanks everybody for joining. Let's see, Dr. Nejad is here. Let's bring him on. Thank you everybody. Hello, hello.
Hey, what's up?
Hey,
How
there
you
you
doing?
are.
Hey,
Good. Did you leave your AirPods somewhere or you have to sell one of your cars to buy one? Buy some?
my ears are defective, man. They don't stay in my ear. I'm bound
Really?
to lose them. Yeah, even
That's
these,
funny.
even these fall out nonstop. You'll see me doing this, but it sounds much better. So yeah, man, I gotta get if I get the pro ones, it'll work because they have
Oh,
those
because
little.
yeah.
Yeah, so I've thought about it, but I got those big headphones. I use them most of the time. I'm
Yeah,
not
those
the
are those are good.
I'm not the biggest user of headphones, anyways, because
Oh my gosh. For
I'm
me,
not
I keep them in
user.
all day.
Yeah. Hey guys, what's going on?
Okay, so I'm gonna put a title up for us, practice management
Oh yeah,
quality
I want to
tips.
I want to grab something too. Give me one quick second. I'll be right back.
Okay, sure. And then I'm gonna tell everybody put comments in comment box, please. Okay, so we're going to be talking today about practice management and minimum requirements. Dr. Najad will kind of introduce it a little better, but thanks everybody for coming.
All right, great. So you want me to get this started?
Yeah, go ahead.
All right, guys. So what we want to talk about today is essentially about the interface between practice and quality, because I hear, first of all, the type of quality that we do in our office. It's first of all, we love doing it. It's takes a lot of energy. We're really trying to maximize every step. But I guess one of the things I always try to drill and stress across to people in courses is that this type of dentistry doesn't have to be 100% the same everywhere, because in any economic model, there is a supply and demand curve where some patients can't afford, if you do more time, more effort, and do all these things, it's amazing, but not every patient will be able to access care. So the important distinction is that quality doesn't mean it can't be affordable. We have a practice that's built on maximizing every single step of the process. But if everybody were to practice this way, the fear I have is that a lot of patients would be left saying, how can I afford this? How can I get something? Where does that leave me? And that's not the goal. So as we go through this, we want to basically understand and address that there's a market for everything. The cheapest, the fastest, most comfortable, it all exists out there, but all of them have a certain quality threshold, and it varies by procedure, but there has to be some level and standard and some sort of measure of what's acceptable. Doesn't mean it has to have like full anatomy or beautiful layering, but it has to be a certain standard. So we're going to
Yeah.
be talking about that and trying to address both surgical and restorative aspects of care and give our opinions on how you can do these different techniques and procedures that we do, and what you can do to cut the costs down, but maintaining what we believe are some of the most important quality standards so that you can fit it into your practice and make it accessible. We're also going to talk a little bit about insurance and patient expectations and so on. So we're really excited to share these things with you guys. We're going to take questions. If any of you have questions, we'll go through them either
We
in
already
the
have questions, Matt.
Oh, good. I'm glad you're watching this. Yeah, when I talk, I zone out. So when you're talking, I'll catch a bunch of them. But, we'll definitely incorporate those things. So is there anything I missed you want to add on to that?
No, I think you really did it well. I think from my standpoint, we both speak a lot, we travel around, we teach a lot of other doctors, and I know that I've gotten these in my questions, afterwards, in my courses, someone will come up and say, Kyle, that's really cool what you do, but at my fee schedule, I don't
It's
have the
impossible.
time to do that, or I can't pay the materials to do that. How can I still get the best quality or something similar to maybe what you're doing or your mentors are doing at what I do? And I just had this from my dad. So my dad was watching a recent webinar,
Oh, yeah.
and it was someone doing like crazy layering on laterals, you know, using 4 or 5 different composites and stains. And my dad said, like, I could never have done that in my practice. You know,
Yeah.
he has, or had, I guess he sold his practice, but he had, you know, kind of a normal insurance-based practice that he just said, there's no way I could do that. I would have to charge a crazy amount. And when he told me, I said, yeah, that's how much Matt charges, because that's what he does. You know, so these questions are real. And, you know, I think our mentors came from the high end. And so we kind of gravitated towards that because that was just all that we learned. But, you know, that's not what the norm is. And like you said, there's some people that can't afford that or don't want to pay that, even if they can afford it, or they don't
Right.
have the time, et cetera, et cetera. So I think these questions that you set aside are really good.
Also, like, I've heard numerous times, like I remember when I was starting my, you know the story perfectly, but I started my practice right out of school, and I had seen that people weren't doing things the way that we had learned in school, like the academic way. And I've heard even in the early days that that's academic or that's not suitable for a private practice. But I firmly believe anything you want to do in dentistry is possible in a private practice setting. It's based on how you market, brand, and convey that. You know, your patients, some will want to sit there all day and get the best treatment and that time, and others are too busy or don't want to pay that much or don't have as much time or only what their insurance covers. So it's all possible, but we have taken what I think is like the most academic in the sense that research based, really ideal concepts and made them reality. Now we're going to give our input onto what that means, because I get these questions all the time. My brother's girlfriend has a practice, and she's asking questions on what do you think is the most important aspects of what you do, et cetera. And these are hard questions to answer, but after having thought about them for a little while, I think I'm ready to give some of those. And having done lectures, I've answered some of these questions little by little. The goal is to help you do the best you can with whatever circumstances you're dealing with. So
yeah, whether that's insurance based, whether you have to work quickly, or whether you have all the time and all the money in the world to do the absolute best. Because,
sure.
you know, that brings up a good point, because just because someone is expensive doesn't necessarily mean that the quality is high, right?
No.
And we see this all the time.
Exactly.
And that's, I think, what is sad for patients that don't know. And they assume that if it's expensive, it must be the best. And that's not always the case, because sometimes, you know, and you've had people in your courses, like I've had people in my courses, some people in my courses are doing really, really quality-based work at very fair prices. And they've done some of the things like we're going to talk about today. And then you have the other people that are doing kind of shit work at, you know, very high fees.
Yep.
And I think it's, that can be unfair.
Yeah, as we go through this, I want everybody to kind of think that the frame of reference for everything you do should be somewhere along the lines of having your ethical standards, but also having in mind how much time you can commit to that procedure and getting a fair compensation, whatever that is. Like in our practice, I've made it a point never to charge more for a procedure to upsell it. So like you were saying about the bonding, I made it so when I do a procedure on average, I'm getting compensated a rate that's consistent, so that I'm not more inclined to recommend one procedure over another. So that meant when I did huge fillings, the price difference wasn't, you know, and especially if I spent an hour and a half on it, it wasn't the difference between like a couple $100 and a couple $1,000. It was closer because I wanted to value my time. Now on insurance, that becomes difficult, but we're going to be talking about how we can really address those concepts in a way that would still make it fair to the dentist, but also fair to the patient.
Yeah. Okay, so first question is the standard of care. What is the threshold for fair quality?
Okay,
From a
so
restorative standpoint.
So in dental restorations, I look at restorations all the time, and when I treatment plan, if I see something that doesn't have great anatomy, et cetera, I'm not going, I got to replace that. So the way I assess fair quality and I mean fair, is that first of all, radiographically, you have to have acceptable margins. Having sub-margin, open margin, overhanging margin, that's never fair. It doesn't matter what price point you're charging, those are just out. You can't see the bond, you can't see how well like a filling is sealed, but you can at least make sure it's contacting and closed and not, just wrong to begin with. So I would say having closed margins, being pain and symptom free, right? You do a restoration. If it's sensitive, that's not really serving the purpose. And depending on the restoration, having a minimum threshold of longevity. So for like a filling, I would say if you have everything else satisfied, about 5 years, okay? If you have a crown, inlay, or onlay, I'd be shooting bare minimum like in the 5 to 10 range on those things. But it all starts with the margins. I mean, if you've already put something in that has poor marginal integrity, open margin, you're just literally putting a ticking time bomb in. And that's not fair, because at the end of the day, we know that's substandard. We know that wouldn't pass in dental school, and it doesn't matter what someone paid. If you can't deliver that is below standard of care. And I see stuff that's stained all the time, but I don't have a problem with that. If it's closed and it's stained, 5 years old, 10 years old, a lot of these composites are much older than bare minimum 5 years. But I would say I'm gonna intervene on a restoration once it already has recurrent decay. But what I notice is I'm not really putting fault or thinking it's the restoration's fault if it looks relatively intact and contacting the margins. But when I see open margin, et cetera, that's where it's hard to say that this was acceptable to begin with. And
well, I have to tell you, I look at thousands of images with Pearl, with my AI company, and so many bad margins. It is crazy.
I know this sounds obvious. I mean, like, as I say it, I'm sitting here going, who doesn't know this? But people do not hold themselves. Like, there's no price in the world that would justify having an open margin. You know what I mean? Like, if you can't do it for that price, we're going to talk about ways where you can save time and do restorations that are fair for the price point. But it's never fair to have it's not a procedure or care or anything to call that, an actual treatment. So,
and do you think that is because I feel like dentists are generally trying to do their best doing the work. Do you think it's that they're not taking a radiograph at the end? Or that they are, but they're just like, I don't really have the time to fix it? Or
I think it's a little more. I mean, like, of all the things I've done, I've always thought fillings are the hardest things. You know what I mean?
I think so too.
I could, it's like, I'm good at them now, but it's still the hardest thing. And everything from, it's like if you start with poor isolation, then you go to the next step, and then everything compounds. When you start off on the right foot, it gets easier. So when we get to some of these things, I'll mention them, but it's really hard to recover from bad preparation, bleeding gums, trying to get a matrix inside there, etc. But I think it's a little more. I think it's the whole compound system where you start off on the wrong foot. Okay, you have a practice that says, we're going to pay $80 for this. So you have to go fast. And, as you're going through, you're limited by time, and every step of the way is sacrificed. And to me, that implies that either the price has to go up a little bit there, or early on is where you have to invest your time. When we get there, I'm going to tell you, I think my priority is the early stages of the procedure up to the matrix being placed. From there, from the time you're actually placing your restoration, if you have your matrix in the right way, we can talk about bulk fill strategies, which are perfectly fair at the lowest price points. You know what I mean? But it's not fair to just start from the beginning, drill sloppy, matrix sloppy, overhanging margin, etc. So I think just, to break it down, dentistry is hard, and we're forced to do things that are a little too fast. We can make them faster. Like right now, I know I can do fillings very fast if I do bulk fill, don't care about anatomy, etc. But right out of the gates, out of dental school, I couldn't. You know what I mean? It took some time. So people come out, they work somewhere, they're told they have to do 3 fillings in this amount of time. They don't really have anyone supervising them to say it's unacceptable. They say it's fine, it's fine, it's fine. And then we get to these types of things, but it's not fine. I mean, there's really no world in which that's fine.
Yeah. So we had a question come in. Someone said, Dr. Stanley, how did you look at open margins? I didn't catch the name. Oh, so that's with my AI company called Pearl. So we look at radiographs with artificial intelligence.
Right. And that's, even an insurance company, if they saw that, they wouldn't reimburse for that, right? I mean, they don't always ask for post. I think they don't really. I did a lot of insurance for a while. They don't ask for post-op radiographs on direct restorations frequently,
Right.
almost never. So they don't know. They ask for pre-op, and that's it. So you can get away with it. But you would know, like deep down, everyone would know that no one would want to pay for that if they understood what was going on. So how about for surgery?
And it's something that, open margin is something that even a patient sees sometimes, like if you show an x-ray, patients are like, hey, that just doesn't look right. Like, you don't have to be a dentist to see that.
Exactly. So tell us, I think for me, that's what it comes down to. Like, it doesn't have to be beautiful. It doesn't have to match perfectly, because bare minimum, what are my priorities in a dental restoration? It's going to be that it is functioning, preventing sensitivity, and expected to last for a certain amount of time without problems. Not forever, but a fair amount of time. You pay more. I heard this saying, and I love it. I really, really love it. In dentistry, the best you can do is buy time. How much time do you want to buy?
Right.
You're literally, you want to buy more time, costs more time. You're buying the time. It's like a trade-off. But why don't you tell us a little, like in implants, because it's so different. You know what I mean?
Yeah.
Now you're dealing with a surgical component. What do you think are the standard of care when it comes to implant placements? Because you and I have both seen some ridiculous implant attempts, failures, surgeries, malpositionings, et cetera. So tell us a little bit about how you look at this.
Yeah, you just said it right there. I think one of the first things should be position. The implant should be placed in the correct position based on the restorative aspect. And that's, I think, where the disconnect comes. If you've restored implants, you've had something where if someone else has placed it, or if you have placed it, it's made it difficult on the restorative side. And I think that's where implant dentistry has gone wrong for so long. It started off, 40, 50 years ago with Dr. Brannemark, where it was like, I only teach oral surgeons. And then it was, okay, periodontists. And then it was, GPs or prosthodontists or restorative doctors. But because the foundation started in surgery, it has been this like, let's put the implant where it needs to go in the bone and figure out how to put a tooth on later. And that's, I think, comes from, again, the original aspect of implant dentistry, which was all full arch cases pretty much. And now when you're in a lateral position and you have 0.5 millimeter on each side of wiggle room, you can't go wrong. Otherwise, your square access hole is off, the material will fracture, you get food trapping. So number one for me would be a good position. And one of the biggest problems I see is actually depth of the implant. And we can go a little more into that later. But so, buccolingual mesiodistal position, and then occlusal gingival position. Number one.
Okay.
Any questions on
it? Is there number 2 and 3 and 4 or any others?
There are two more.
Two more?
Or okay, sorry, there's 3 more.
I don't want to take any away. So no questions on that. I agree. So like positioning is very important. I guess one question that would come to mind is, do you believe that in some cases, I know how big you are on guided surgery and I'm very on board. Do you think that being in the proper position requires guided or not always? I mean, I know that's the best approach, but is that an absolute requirement?
I think pilot hole guided should be.
Okay.
Because nowadays with the technology bringing the price down, I mean, you can get a pilot hole surgical guide for like $70, maybe even $50, depending on the system that you're using. Okay. And then if you're doing pilot hole, you don't need to buy a full guided kit. And, full guided kit can be $7,000, $10,000. So that's just one pilot drill that you have to buy. And starting that will get you, 80% of the way there. Okay. The problem with pilot hole drilling only is that it doesn't guide your depth at the final implant placement. And I think that's really important for my next topic.
Point.
Okay, next point. Yeah.
One more thing on the positioning then. So when you talk about positioning, if this takes from one of your other points, just tell me it's coming up. But what about when people plan things, but they, let's say, don't use CT, but they do not factor in so they don't factor in the CT, and everything looks good, position's great, contour is great, but the whole buccal bone is, is that
Yeah.
part of one of your other points, or does that fall under positioning?
I didn't even think about that, but yeah, it's
Because
so
it could look great, right? You
it's
can have
so
implants
ingrained
that
in
look
my
fine.
head. Yeah, and originally guided surgery started like that. It was, let's look on the model, plan where the tooth is, and then just drill in that position. And you may know if there's bone there or not. But yeah, I didn't even think about that because CT is such a no-brainer. But there's still a lot of people that are doing implants without CT scans, and I really think that that is a standard of care.
Okay.
For sure. Yeah. So thanks for
Right?
bringing that
Because
up.
it's got to be in, like, if from what I'm thinking, when you talk about position, there's the restorative aspect and getting some sort of good contours and reasonable, like, final restoration.
Mm-hmm.
And that has so many benefits. But in addition, there's the ticking time bomb where if you had planned it and were able to go, like into the bone, what would your disadvantage have been? Sometimes it's position, but other times it was just a matter of another 0.5 millimeter or 1 millimeter more lingual. And so having that information, I think, is important, because a lot of things that we've had to go in and scan or redo, or, like, let's just say, like, full mouth case with numerous existing implants, we're like, oh my God, all the buccal bone is gone. And you can only imagine. And when we have traced back the previous surgery, we confirmed it wasn't done with any particular guided aspect. And, it's holding up, but I don't know. Like, to me, I would say that that's borderline standard of care. It was meant to go inside the implant, inside the bone. If it didn't start inside the bone because of planning, I would think that that's, if it started and things changed, that's of course just aging and potential complication. But if you just never planned for it, the saying, if you
fail to plan, plan to fail.
Yeah, exactly. Okay, tell us your next points.
So next point would be stable bone and tissue. So that'd be peri-implantitis. And in the past, that was very accepted. But now with the biology that we know and the research and stuff from Thomas Linkevicius, we know that we really can't avoid peri-implantitis in most cases. So that'd be number two.
You said you can. Yeah,
we can, yeah. The ones where we can't, I think, is where research is coming that AI will actually help in, which is like genetic factors of people that we haven't been able to prove yet, just because of who you are. The doctor did everything right, the patient did everything right, but for some reason, this still happened,
Gotcha.
And those may be more of, like, how you and I talk a lot about, like, true titanium allergies and things like that.
Yep.
No cement excess. So this is kind of the surgical part of what you were talking about with margins. Intact margins, no cement excess. We know cement is really bad. It's the problem has been really ingrained in restorative dentistry that, well, this is how I put a regular crown on, so this is how I'm going to put a regular crown on an implant. And unfortunately, it's just a bad idea and
it's avoidable. It's avoidable with the right planning,
Yeah.
And it doesn't have a cost. I mean, it's just a matter of going back to step one, like, this is what I meant about things building up on top of each other. Poor planning leads to deep margin, it's like, it's really hard to recover. Every step, it becomes harder to recover when you started off wrong. That's why I really think a lot of the most important items for me come in the early stages, and they're very achievable, and most of the time they're not even expensive. But as you go through, the parts that are like the final result, the shape, the anatomy, the color, the contour, those are luxuries. It's, if you have it in there and it's healthy. Yeah, exactly. Okay, so that was your
that's like a case that I'm working on right now that someone referred to us. Is it came from the restorative doctor, and the crown on the implant ruptured. And so initially you think, like, oh, it's the restorative doctor's problem, right? And then when you start looking at it, you have it, in the lab, and we're looking at a physical model. The reason the crown broke was because the implant was placed a little too buccal, and this was the only way that the restorative doctor could do the crown. And so, who placed it, whether it was that doctor or not, but like you said, the beginning parts can really save you, and it can make it less expensive in the end.
And you know what else is interesting about planning? Sometimes you plan and you have to pick a position that is not the most optimal restorative position. But because you planned, you were able to assess and make that decision in an informed manner. I have a patient right now that we have to do 3 implant placements. She wants zirconia implants. Anybody who knows me knows I'm not the biggest fan of them, but I'm open to them. I think that there is a place for them. It's not my first choice. I'm very cautious on them, but I see the potential. I just don't think it's necessarily the obvious decision for everybody, but there's a subset of patients it would. Now, when you look at her bone and everything, all along there's been discussions about, oh, implant here, implant there, and I keep looking, I'm like, I don't see that happening. But I'm not doing the surgical planning, I'm doing the restorative planning, and there's another surgeon involved. So we are now deciding where to go. And the important thing is, instead of having the implants placed and going, hey patient, look how this contour is, I'm trying to educate her and show her this is what it will feel like. I'm going to make her a removable prosthetic that shows her roughly what it would feel like against the tongue, etc. So sometimes you plan and it doesn't guarantee that you get a perfect shape. It means that you've perfectly planned what's achievable in that area, and then you avoid, you see those implants that come out of the anterior maxilla at this angle. Well, I mean, usually that's poor planning, but maybe sometimes possibly it's the only option. And when you've reviewed it and you've specifically chosen it and you've weighed all options, then it's just proper planning. It doesn't have to always be that's a mistake. It's never a mistake if it was intentional.
Especially in implant dentistry, we've all seen crazy things that have been there 20 years, and maybe it's one of those kind of cases. So the last for me is using biologic materials. So materials that, especially subgingival, is what's important. So using polished titanium, polished zirconia, subgingival. That would be the last thing.
Got you. Yeah, makes sense. Should we do the next point?
Yeah. Okay. So next point. Critical items you would require, in your opinion. What are the absolute requirements to do the work? Do you expand a little bit on what that question means?
Yeah, so we've talked about standard of care. So now it's like, how do you achieve these? So from a restorative standpoint, let me just answer some of these. So for me, the critical items, let's talk about a filling, for example. It doesn't have to be the most beautiful prep, but it has to have clean enamel margins, clean as in not caries, not demineralized. You got to have a sound substrate, and it's got to at least be caries free. From a biomedic standpoint, caries free circumferentially around the dentin. Hold on a sec. Around the DEJ. So we have this concept called the caries removal endpoint, and the idea is that you can get a strong, successful restoration if you have a strong seal on the periphery of the tooth, which means the enamel, the DEJ, and 1 or 2 millimeters of your dentin. So you spend your time, and it's very safe. And I say spend your time, but it's actually very fast because you can clean the periphery without fear of pulp exposure. And so no matter how fast or slow you are, that's up to you, but it's not a slow concept. To be requiring caries free on the periphery is a very reasonable and fair expectation of our profession. So you start with that. Before you even start that, adequate isolation, which to me, isolate is still adequate. Okay, I like rubber dam much better, but isolate is adequate. There's studies on it. It helps. I would just guesstimating. I would say it cuts down contamination, moisture, etc. by probably on average 80 or 90%. The difficult scenario is gingival margins or subgingival areas, etc. Okay, you can try
lower jaw that don't have deep vestibules or something where you can still get saliva pulling up.
And I found with those, when you use it a lot, you find the tricks, the cotton roll, there's certain things you can do to help with those. But basically, I've been able to do a lot of good dentistry with isolate, and I've seen a little bit of the stain margins, etc., but by no means a failed restoration. So isolate or equivalent, like any brand of intraoral suction that retracts the cheeks and tongues. Okay. Without that, it's just, at least not for adhesive dentistry, and to me, standard of care and critical items are a composite restoration right now, something resin composite restoration. So you do that. Next, and if you've already have the isolate and everything, the only difficult part left is tissue management, and electrosurge works, laser works, even viscostat clear can be used to like cauterize the tissue. You leave it for a couple minutes and it really does a good job. So having good tissue control, and once you get a matrix band in, if it's positioned well, most of the time you've already cut down any heme or bleeding from getting into your prep. There's actually a really cool product. When I didn't use isolate, when I didn't use rubber dam, I used isolate, my matrix band for like a sectional system, like either Garrison, that was my go-to. Then the wedge, this was very important. There was a wedge that Garrison makes. I think they still make it. It's called the A+ wedge. Have you heard of this one?
Is that the one that has the like the wings on it?
No, better. It has astringent in there. So when you put it in, it does create hemostasis and it works really well. So you're wedging, but it's also stopping bleeding right there. It works really well. So I only use that when I didn't use rubber dam. And early on in my career, that was a lot. So like I did do that for a while. So, you know, good hemostasis. Are you losing me? It looks like it's cutting out. Can you hear me?
Or you're back.
Okay, cool.
Yeah.
Great. So from there, immediate Denton sealing and resin coating, which is, it sounds, for those who don't know it, it sounds like, oh, great, another step. So it's the first step to every.
What's the timing on that? Because I know a lot of people ask you that. How long does that aspect take? You've done your isolation, that takes a few minutes.
Yep.
You know, you've done your peripheral seal. You're about to do your immediate Denton sealing with resin coating. What is the time from when you start that till you finish it?
Yeah, so like backing up all the steps I talked about, honestly, I would say if you're already prepping and doing caries removal, I think on average we're talking, you know, a couple extra bucks for good isolation, maybe 2 extra minutes. I mean, you still have to remove caries. I'm not even saying your margin has to be perfect, you know, I'm just saying caries free, you know, like that's the most basic expectation. So a couple minutes on that side. Now, when it comes to immediate Denton sealing, how long does that take? So you have everything in place to go, 2 minutes max. You prime, okay? Depending on what system you use. I don't want to get too specific because I'm really familiar and recommending total etch and self etch systems, but either one of them, 2 minutes max, maybe even just 1 minute. Because if you add up the time, let's use self etching system. You prime, you air dry. That whole
etching
step
first, right?
No, with self
together, that's right.
With self etching system, you have the option of selective etching the enamel, but if we're talking about minimum requirements, you don't need that. It still does etch and bond. You get a lower bond strength, but if we're talking about minimum requirements, that's fine. You get a bond, it does work, and if you're doing these things for like $100 or $80, I think it's very fair to do these steps. You know, the problems we see are like the other things. So you prime everything, and we're talking 30 seconds max. You prime for 10 to 20, you air dry, priming is done. Apply your adhesive and cure. Okay. I like to wick up the excess adhesive, but still we're talking another 30 seconds. So it's 1 minute there, and then flowable on all the Denton surface. And that takes not a minute. You know, you put some flowable down, you use your probe and drag it around, cure again. Okay.
So we're talking about less than 5 minutes to potentially increase your bond strength 400%.
Well, in this case, that's a good question. So up to this point, the minute you cure your adhesive, your bond strength has started, right? So from that point, if you want to increase it maximum, you have to like wait hands off and either do low stress increments, like start filling incrementally, or work on,
or takes time,
or work on another tooth. But so here's like, if you're in an office that does these things, my experience has been you're usually doing a few teeth at once. Okay. So you could, right. I mean, I'm not totally an expert on that, but I usually don't see a lot of these offices that do $80 fillings doing one at a time. I usually see them doing a quadrant or so on. So you basically would do the steps we talked about and then do the same on the next, you know, you could prep them all at the same time, but do this, then go back to this one. And it's been a few minutes. If you wait 5 minutes, it's a great amount of time. But if you're on a budget, even if you don't wait, you know, I'm talking about minimum expectations of quality. Okay. Just getting to the point that you've resin coated, used a good system and everything, you've already, because what's going to happen is when you put on the composite, especially if you bulk fill it now, if there's too much polymerization stress, most likely the gap is going to be between your composite and the flowable, not between some, which it's better, you know, it's like, it's not perfect, but it's not likely to be a sensitive restoration. You're still likely to have, you know, good margins from everything else we've talked about. You're not likely to have symptoms. So this is, you know, like, I know, give me any patient, I can do this technique. I can do that type of filling in, my drilling is slow, so I'm not gonna lie, but let's say like whatever your drilling is, from drilling to finish, I can be doing that in like 5 minutes tops. You know what I mean? Because we just said the immediate Denton sealing, and if I have no other tooth to work on, I'll fill that one. But if I have 2 or 3 others, I'll go 1, 2, 3, come back and fill this one, come back and fill this one, come back and fill this one.
So allowing that bond to mature, even a few minutes, will help in that case.
It's good, and that's important because people have to realize that resin is a reaction. You know, polymerization is a reaction. I mean, and the light started it, and there's no exceptions to this. It's not instant. It's not like you flip a switch and it went from like flowable to solid just like that, you know. It's not a snap. It's kind of a snap, but it's not a full polymerization, and it takes time, up to 48 hours. But I would say in the first, if you look at the curve of these things, if you have a graph like this,
I remember you
in the early stages, it rises, then it slows down. So like, you know, going from 5 minutes to 48 hours, you get another maybe 5 or 10%. But in the early stages, if you have too much stress, it never actually makes a bond. And if something doesn't bond, it never bonds. So the worst thing you can do is not put the flowable, then bulk fill it instantly. Then you have a very high chance of getting separation in between your dentin and your adhesive layer, and also using poor quality adhesive. So the difference in price between a good system and a cheaper system is relatively negligible on a per use basis, you know? So if you use a better system right off the bat, then you're less likely to have these problems. And I'm talking like $50 difference for the bottle, but the bottle can handle like 50 to 100 restorations. So it's like maybe $1 more.
And from a practice management standpoint, you bring up a good point with the sensitivity, because sensitivity can be an expensive thing to manage, right?
It is, because nobody's okay with it, right?
Yeah, the patient comes back in. Are you going to charge them again to, you know, do something again? Or when they come in for a post-op, you know, most of the time you don't need a post-op for a composite, but when they come in with sensitivity, then you're taking up chair time with that too. So doing it right, taking those first few steps like you talked about with isolation, getting the margin good, peripheral seal zone, and then doing the immediate dentin sealing with resin coating. It's not that many steps. You just have to do it correctly. And it doesn't take that much time, and it's not that expensive.
And somebody asked, so you charge extra for IDS? And no, I'm not. This whole conversation isn't about charging extra. It's about what I believe are the minimum requirements to give a fair quality restoration. And also literally the extra, I would say at most we're talking an extra 2 or 3 minutes, but I would firmly say that you would save your practice at least that amount of time in post-ops, etc. You know what I mean? The benefit of these things too is you have to factor in all your time. You know, to be done in 15 minutes but have to do a free post-op, it doesn't really help you when the patient's sensitive or a replacement and so on.
Even your team's time too, when you think of that patient's going to be calling, asking your team, oh, I'm sensitive, what's this? I mean, you know, our front office could be calling, getting another patient in, scheduled for treatment, you know, pre-booking things. So it's the whole idea. And also you got to think from a marketing standpoint too.
It's true.
You know, and two people are sitting having lunch and someone says, oh yeah, I just got this filling done and it's just driving me crazy. And the other person says, well, I got a filling done. I never had any sensitivity.
Right. And that's a reasonable expectation, right? I mean, like who's saying I want, like, first of all, half these patients half the time we're diagnosing them and doing these things, they're not coming out. We put it on our informed consent, but I'm going to tell you right now that they are avoidable over 95% of the time. You know, it's not supposed to be expected or normal. It's avoidable. It's only so normal because of the technique. So the word immediate dentin sealing, guys, just to clarify this for everybody, is that all direct composites by definition have some form of immediate dentin sealing. The fact that you cure the adhesive before you move on to the filling is immediate dentin sealing, okay? But if you expand on that term to do like optimal immediate dentin sealing, or like give it the best immediate dentin sealing, maybe you've added 1 minute, you know what I mean? So you're not doing an extra step, you know? You're just using the best product and maybe an extra minute of time to do that step better, but you're doing it. You know, everybody, if not doing immediate dentin sealing would go like this. You prime, you put your adhesive on, you don't cure anything, you put composite on top of it, and you cure your composite and your adhesive together. That would be not immediate dentin sealing, okay? Like delayed dentin sealing or something. We never do that on direct composites. The term really has, I use it everywhere for like simplicity. The term is really meant for indirect restorations where it's much more common to like not do it, but to try to bring things together, I try to like draw attention to the fact that direct restorations are getting immediate dentin sealing by every provider essentially. There's very few people that don't cure their adhesive. Some do that, but it's very, very rare, and it's not a good idea.
Yeah.
I think we should maybe just talk about the next couple and then do yours at the same time, because it's like they almost flow together, you know, like patient expectation. So like for me, so from this point, by the way, immediate dentin sealing, like I said, you go to the next tooth if you can. If you have nothing else to work on, go ahead and fill it. The whole 5-minute thing is an optimal thing. It is good, but if your price point is $50, $80, just the fact that you at least got those couple things, caries free, periphery, high bondable surface, good bonding agent, fair isolation, those were the most important aspects. Anatomy and incremental layering, those are phenomenal, but they're not going to come at $80 for a filling. It has to be fair to you as well. So I think if someone's paying $80 or $100 for a filling, and it's taking you, this whole process takes you 25 minutes or 30 minutes, it's already I think it's still unfair to the dentist, to be honest, but you don't owe anything else. You know what I mean? That is reason, if a good margin, whatever, then you'd bulk fill. And my preference actually would not be to use a bulk fill composite material, but just bulk fill with something like APX. The problem with a lot of those ones that are actual bulk fill materials is they are much essentially
less densely
softer.
filled, right?
Well, the modulus is lower, so the stiffness is lower essentially. And while that is good for shrinkage stress, it's not good for mechanical properties. Looking at all the options, I'm okay with there being a slight, first of all, the shrinkage stress difference isn't huge when you compare the two of them, but the stiffness is. So I would use something like APX, a solid restorative composite, and either bulk fill or 2 increments. I mean, sometimes literally it takes less time to... Exactly. But I wouldn't do anatomy decoupling, all these things that I love to do. I think those are when people pay for them. They take more time. So the minimum requirement for a fair restoration is those things. And when someone is on a budget, and it's functional.
Yeah.
You know, it's not perfect.
Biologically sound.
It's not perfect, but it's acceptable. So that brings me to patient expectation. So like, what does a patient expect when they get these? Well, in our office, a combination of like I would say our patients value the anatomy, how it looks, minimally invasive, all that stuff. But deep down, the things they really care about, if I took anatomy out of the equation, I wouldn't lose that much business. I do it because I enjoy to do it. I know it has some advantages, especially when you're layering cusp by cusp. My patients appreciate that they trust me to do the best, but they're not specifically going, I need better anatomy in this molar or the premolar, but they go hand in hand. When you're sculpting a cusp, one cusp at a time, you are essentially buying time, decoupling. There's all these different concepts. But from a patient standpoint, their expectation is that it's not sensitive, that it is going to hold up. Depending on the price point, I think a filling should be, insurance says 2 years, right? I think it should be 5, because if you have to go in every 2 years, you know that that pulp is not going to
Yeah,
survive, and
not
you're
gonna like
giving
that.
into, you're giving into the whole concept that dentistry is guaranteed to result in root canals and crowns. So I think 5 years is like the minimum reasonable expectation. I also think that even poorly done composites typically last that long, so it's very reasonable to expect 5 or more years. Okay, and what happens is when you think about insurance fee schedules for these things, the question you have to ask yourself, I've seen different prices. I remember the first composite I ever did in my practice in Simi Valley. It was a 2 surface composite and it was like $72, and I spent 3 hours on it, And I was just like, how am I ever going to make money
They
doing
got a
this? But I
great
thought,
value. Yeah.
they got a great value. I did this guy's whole mouth. He's still a patient, actually. He comes to our office every now and then. He lives in Simi Valley, but he comes now. I did his whole mouth, and the most I probably charged was about 150 at the time for like an MO filling and a separate DO filling.
Yeah.
Two surfaces at $70, $75 or something. But my concept was, I'm building my patient base. I'm gonna raise my fees. That wasn't fair to me. I can't do that. Like, I wasn't making money, but I was building my habits, my techniques, my clientele. And so I think that I left that insurance right away. But at that $75 price point, I could have done the bulk fill. It would have been, not 3 hours. You know what I mean? The time I spent was a combination of a lot of things, including rubber dam at that one. But
Yeah.
I think with insurance, the important thing is to look at your goal of compensation, whatever it is. $100 an hour, 200. You need to look at your overhead, what it costs for your staff, your rent, and everything, and then how much you want to leave, and decide from there. But you should never let insurance make you do substandard quality. Unfortunately, they pushed it to that level, very close. Okay, but I do think that HMO offices and high volume offices can still be held to the same standards of doing fair quality, like we talked about. It's doing nobody service to give them the overhangs and this and that. So if you can't do it on the fee schedule, it's your duty to try to find a way to leave and educate people as to that. It's hard to play tricks. I've seen people like upsell the patients, but
Right.
if they don't go for the upsell, you can't go back to the overhanging margin. You have to give them the bare minimum. So if you're going to upsell, I know this strategy, and I hate the word upsell because it implies that it's not a valuable upgrade. I'm talking about a valuable upgrade. You can go and you can tell the patient, if I layer it and do this anatomy and spend more time, it's good. And there's ways. I've seen somebody do this. I've never done myself, but I know somebody that'll take a piece of rib-on fiber, and rib-on is like, you know what a rib-on is, right? So it's that fiber that you can put into a filling, and if you put that in and you do incremental filling, you can specify it as an unspecified restorative procedure. And if insurance doesn't cover, the patient's still responsible for it, from what I've been told. It makes sense knowing what I know about insurance. So you're not charging for the fiber. I mean, when insurance looks at it, it almost looks like you're charging for the fiber, but you're charging for the difference between a bulk fill and spending the time to do a stress-reduced application technique. And rib-on just so happens to be like the material that falls under the, because you can't do a code for I layered it and I did increments,
Right.
but you can do a code for I did a filling incorporating rib-on for stress reduction, lump it all together, and it's a valuable upgrade. So that works really well for some people. I can't like attest to it myself because I haven't used it in that way, but I know that the filling is better. So that's a fair approach. But when they don't pick it, it's not fair to go back to like, oh, they didn't want it, so I give them garbage again.
Right.
So I think people need to really look at their insurances. There's some that are fair. There's some that aren't. I know everything that happened with Delta made it very unfair for a lot of these things, but it's our responsibility to hold the standards. You can't base it just on the insurance. We have to fight back against that and work on that.
Yeah, I'm going to remind everybody, put your comments in the comment box, and then we'll get to them at the end. Okay, so we've talked about standard of care from the restorative standpoint. We've talked about the critical items that you need, and patient expectations. Anything else on patient expectations for that?
No, I think, and I covered the insurance and fee schedules essentially. I think we can have you answer. I'm just going to answer this one question that's on that note. Like, what would be a good appointment time for a class 2 composite? I think that if you're doing the reasonable quality, I would be shooting for 1 hour for 2 composites, you know, 2 or maybe even 3 composites. If you can do a quadrant or something like that for one, maybe 30 minutes of doctor time, 10 minutes of assistant time to seat the patient, take the blood pressure, stuff like that. But, and I mean by good time, I mean if you're not doing incremental filling, like the basic requirements of the filling, because by the time you've cleaned it out, you can really get this thing done in about 5 minutes if you're doing the reasonable quality, not the best. Now, if you can charge somewhere in the middle, there's a lot of things I would change, you know, incremental and so on. But if you're doing the minimum, this is my threshold. And for a crown, I would say depends on how well trained your assistants are, but doctor time could probably be around 40 minutes, 30 or 40 minutes. And then assistant temporary, I make my own temporaries. I know it's not easy. I don't see assistants that do them well, but remember we had an assistant that did it incredible. We had one assistant that did it better than I can make them still. And she was essentially a lab technician, but she was in our office doing temporary. So depends on your setup, but I would say 40 minutes of doctor time, probably 30 minutes of assistant time in that type of office. You know, I'm still big on taking my own impression, but you have to understand things are trainable. You know, like you can't say assistants can't take a good impression. What you have to say is it takes a lot of training to make an assistant take a good impression. It's not a fact. It's a matter of how much time can you invest. But the problem is to say they can't and not train them and then just live with that forever. That's the problem. All these things are trainable. It's just a matter of how much time and effort will you put into training. So I think crown appointments could be 40 minutes of doctor time, 30 minutes of assistant time in the low quality, not low quality, in the fair quality, low compensation insurance realm.
Right.
Okay. Your turn, buddy.
Okay. So I'm wondering if we should end and come back because we probably only have like 7 minutes and then do the rest in another one. Well, let's end it because Instagram will cut us off.
Okay.
Oh, but then we'll lose all of our questions. Let's see.
Let's try. Let's try. You don't want to try?
Look at the questions that are related to you though, because a lot of these are kind of restorative. Okay. What is your opinion on laser cavity prep?
I've done a lot of research on that. There's nothing wrong with laser cavity preparation. I prefer for margins using a burr. I don't mind using a laser for Denton. There's some papers that look at the bond strength, etc. But my favorite, like the reason I don't use it is because my favorite that gives me almost all the same advantages, maybe even more actually, is air abrasion. So I like air abrasion. It gives me precise control. It's very selective. I use it for other stuff in the procedure. So for the same reasons I would consider using it, I prefer to use my air abrader. And the other thing is electric handpiece. So the combination of the two, but it doesn't mean you can't use it, but you definitely aren't getting a specific advantage over my protocol. So it comes down to preference, you know, and my fear was that it lowers bond strength, but I've looked at enough papers to see that, you know, settings do have an impact on it, but it can be done very fairly where you don't lose bond strength, but you need to know your settings, what type of laser, etc. And it doesn't improve my bond strength over the way I do it. So I don't want to add any extra complexity. It needs to have an advantage, which I don't see right now.
Yeah. Okay.
Any other questions?
Saying, how do you charge for minimally invasive restorations? I'm not sure if I truly understand the question, but everything we do,
is minimally invasive. Yeah. So I never treatment plan this versus that. I will talk about in an informed consent that an inlay or onlay is my first recommendation. Crown is an alternative, but I don't recommend it because we take away extra tooth. But I definitely don't have a price difference between the two. You know, so one way I encourage this type of stuff is based on what I believe and also my time. I don't take much
that's
longer.
Kind of just our philosophy, right?
Exactly.
I mean,
and for me,
if you come to our practice, you're going to get as minimally invasive as possible.
I spend a little bit more time on average on an inlay than a crown, but not enough that I have to charge differently for it. So in order to neutralize any benefit of this is better or upgrade, indirect restorations are the same fee.
Okay. Next question. Isn't making more direct and less crowns / indirect less rewarding economically? So they're saying
More
like,
direct?
if you're doing more direct, you're not going to make as much money.
Well, okay, so the problem I see with that is it's only true in insurance-based offices where you're incentivized to upgrade. You know what I mean?
Right.
Like, and in other words, you look at it and go, up, structurally compromised, needs a buildup in a crown. Yes, but in if you want to break free of that, it's very hard to break free within like a set of rules that insurance imposes on you. Insurance is putting all these rules on top of you and you're trying to play within the rules. Then all of a sudden you're incentivized to do things which I would consider unethical. Like if you don't think it's necessary and you're doing it for compensation, it's because of your restraints. In our practice, I made it so financially the difference is negligible. I charge for the direct
Right.
filling and the inlay, essentially the difference in the lab bill and the extra visit. So they balance out. Still, technically, an inlay makes me a little bit more money, but not enough where I want to. You know what I mean? Just a little bit
Right.
more, maybe another $100 or $200, but not enough where I want to go through and do that. I don't want to be encouraged to try to do something for money. Now, in insurance based, yes, that does come into play, but the problem is you can still do certain things. Like if you're going to do a filling versus a crown, that's a big jump. But if you're talking about going from filling to 3/4 crown, there's still some good reimbursement on these things, and onlays are also covered, etc. So there is ways to fall in between, but it does do that. So that's why I told you some people, when they want to do a filling, they do that unspecified code and they charge extra for the filling so that it's taking away any incentive to go with crown. So they're getting what insurance pays, plus I think it's like $250 or $300 from the patient to do a biomimetic filling, and they're happy with that. I know people that do that approach.
Okay. And then the last question on here, not necessarily related to you, but kind of just related to both of us. I just don't want to lose the question when we go to the next one, is what do we think about using care credit as a way to maybe help patients out with the treatment?
Yeah, so I think anything that helps your patient. Are we still there? Okay, so anything
We're back.
that helps your
Yeah.
patients like that is good, but the problem that we've had in our office is not enough people utilize it. So our staff, like anytime we go to use it, our staff has to like try to remember the login,
Relearn
how
it.
to use it. Yeah. So if you can make it a normal protocol in your practice, I'm completely for it. It takes like I would offer personally the 6%, the 6-month 6% option, and just stay there, which means you get the patient pays no interest. You take 6% out. It's only 3% more than a credit card, give or take. And it helps both of you out. It's a good compromise. I wouldn't take 20% and all these other ones unless the patient wants to take the interest. But offering those, I think, is a fair and good way. But my caveat is, if you don't use it routinely, it slows you down. The number of times that we've talked about it, staff comes, did I do it right? Did I check it? I want, like, if you're trying to be efficient, you have to get an efficient protocol, which means setting your rules and not going outside of them. So like, I'm really big on, you set your system, you follow the rules, stop making exceptions for every single patient, because the exception means the staff has to ask you and you get bogged down. And what we want to do is dentistry, not like constantly trying to figure out exceptions and what we can do and how we can accommodate. So find something that works for most people, stick with it, and care credit, I think, is a good option for a lot of those things.
To expand on that, we have to remember what like our UCR fees are, let's say, and then insurance is basically a discount plan, right? It's I'll give your patients a discount if you send them to me, is ultimately what it is. And if you're already taking a discount on that, and then like you said, you take the 20% discount on top of care credit, you're down 40, 50, 60% off of what your kind of normal fee should be. And that's when I think people get in trouble.